waiver renewal application, and followed by a public comment period. So Lori Coiner, Senior Medicaid Policy Advisor, will be presenting today. My name is Hildy Hinkle. I am the 1115 Waiver Renewal Deputy Project Director, and I will be facilitating. I will also be coordinating the public comment process. Just a few things about the meeting before we get started. Please note that all lines are muted. However, please feel free to use the chat box for questions and comments throughout the presentation. We will read your question and respond, but may hold your question until there's a pause in the presentation. Please note also that this session is being recorded and real-time Spanish translation is available by clicking the interpretation icon on your screen. Next slide, please. So as I mentioned, we'll be starting with a presentation. What is a waiver, what the waiver can do, what the waiver doesn't do, and what is changing, or what we are proposing changing with this draft application. There will then be a public comment period in which we will get feedback from the public on what people think of these changes that we're proposing. Those comments will be considered as we craft the final application that will be submitted. Next slide, please. So OHA is accepting public comment on the draft application for the 1115 demonstration waiver through January 7th, including at today's forum. So if you are making a formal public comment, we will need your name and your organization if you are here on behalf of that organization. We will document your statement exactly as you present it and enter it in the public record. Please remember that comments are welcome through the chat box during the presentation, but we will not be documenting those comments in the same way. We will consider all feedback when revising the draft application for submission, but this public comment portion of the meeting provides an opportunity for people to submit a formal comment into the public record. If you do not provide a comment today, you do have other opportunities, including at other public forums and in writing. And we will share more about those opportunities at the end of the presentation before public comment begins. And that information is also posted on the OHA website. Next slide, please. If you do provide a public comment, this slide explains what information will be made public and where that information will be available. Again, this only applies to comments received as part of the public comment portion of this meeting. If people want to ask questions or make comments during the chat or in the chat during the presentation, we will consider those comments, but we will not be adding your name and statement to the public record. And we hope that this provides an opportunity for everyone to be heard in a way in which they are most comfortable. Next slide, please. Oh, sorry, I just got kicked out of my computer. Unfortunately, so I'm without my notes, but I will just continue. So this slide explains the public comment process. So each person will have 2 minutes to provide a verbal public comment. If you have not signed up already, there was an opportunity to sign up through a survey, but if you have not signed up already, you can sign up by adding your full name and your affiliated organization, if you're here representing one, to the chat box, and we will add you to the list. If you already signed up in advance through the survey, for example, or reached out over email, we already have you signed up on the list. Next slide, please. Okay, now I will turn the meeting over to Lori Coiner. Thanks.
Good afternoon and evening, everyone. For those of you that don't know me, I'll go ahead and introduce myself and then dive in and give you just an overview about kind of the rest of the evening. So I'm Lori Coiner. I was Medicaid director until the beginning of July. I'm now the senior Medicaid policy advisor for the Oregon Health Authority, and I'm focusing solely on the waiver and the waiver work. And for the next little bit, I'm going to walk through what a waiver is, what a Medicaid waiver is, for those of you that are unclear. It's actually a little bit complicated, and so we wanted to make sure that we walk through it just to ground everyone in what a waiver is and what it isn't. And then I'll take some time to walk through what's in our draft application that we will be submitting to the federal government, and more specifically, the Center for Medicare and Medicaid Services. Next slide, please. So even at a higher level, what is Medicaid and the Oregon Health Plan? So Medicaid is a federal program. It can be thought of as what a federal and state partnership. And the reason that I say that is there is money and funding that comes through state government as well as federal government in order to pay for the Oregon Health Plan or for states' Medicaid programs. Each state is required to administer a Medicaid program. Also, there are 6 territories that have Medicaid as well. Well, 5 territories, and DC has its own program, Washington, DC. And our program in Oregon is called the Oregon Health Plan. And our delivery system, or the way that we deliver care to members through the Oregon Health Plan, is organized and managed by coordinated care organizations. And these are local health plans, and they cover your physical or medical health services, dental services, and mental health care. Also provide some other types of non-medical supports for people to help them stay healthy. Right now, more than 1 in 4 Oregonians receive their care through the Oregon Health Plan. And the Oregon Health Plan offers free health care coverage for low-income Oregonians. Next slide. So what is a waiver? Within a state's Medicaid program, we have rules that govern how we need to, the minimum services that we need to provide and how we provide care. Those rules are twofold. We have what's called a state plan that lays out, the basics. And then also we have federal rules. For example, the managed care rules that lay out how, our state, for example, coordinated care organizations need to operate. States have an opportunity to waive some of those federal rules, and that is what a waiver is. So what happens is a state like Oregon may decide that we can provide care in a more innovative way that provides better quality, better access to members, and won't cost the federal government more. And so we make a request to waive those federal rules to have a different system than kind of the basic requirements that a state has to have. So an example in our waiver is our coordinated care organizations the fact that they're local and that they are community-based was required. We had to get a waiver for that. In most states, their health plans that manage Medicaid have to be statewide. So that would be just one simple example of the kinds of things that are in a waiver. In Oregon, we have had a waiver since 1994, and they are called, the official term for them is an 1115 demonstration waiver. And we need to demonstrate across 5 years that the ideas that we propose are effective and do provide better care for Oregon Health Plan members, but that care doesn't cost the federal government more. So then you have to renew after the 5 years. At the end, towards the end of 5 years, you work on a renewal, and our state has always worked on renewals and then asked for another 5-year waiver. And so we are in the process right now of working on a renewal, and our current waiver ends in June of 2022. Next slide. So I described this a little bit, how it's recurring in Oregon. We go through this waiver process every year. I think another important piece to understand is that we have many things that we can do to change the care of our members without having it be in a waiver. So an example is we can change policy, or there can be a rule change that we can make in our system, or we can also use what's called a state plan amendment. Waiver renewal is really focused on rules that we need to waive in order to operate our system. They're complicated, they take a long time, and I think the most important piece is that the federal government has to approve it, and they can't, it's to their discretion. So when a state puts forward a waiver proposal, a negotiation begins between that state and the federal government, and the federal government ultimately decides on each of the policies that you put forward whether they're going to agree or not to it. And often in that negotiation, there's back and forth, and sometimes the ideas maybe change a little bit in order to reach agreement. Next slide. I talked about this a little bit already, that our waiver that we're working on right now is called an 1115 Medicaid demonstration waiver. Medicaid programs, there's other types of waivers. I'm not going to talk about them, but they this is a specific type that allows us to waive, like I said, the federal rules. And what we need to the kinds of things that we can change in an 1115 waiver are who is covered under our Oregon Health Plan, what benefits we provide to our members, how much people may be charged for cost sharing. In Oregon, we do not charge individuals any money. We will continue that, so we don't have, that doesn't require a waiver. How providers will be paid, and because it's called a demonstration, we have to have an evaluation at the end to show whether these changes that we made did improve the care of members and did not cost the federal government any more money. Next slide. So some of the things that must be included in an 1115 waiver request. The first is you need to show, where I was saying it can't cost the federal government any more money. The federal government calls that budget neutral. It needs to cost the same or less. We also need to show, like I had just mentioned, that there is an evaluation plan, and how are we going to see whether this new type of care that we're proposing leads to better health outcomes for our members, leads to more access to services for our members, and so forth. And as I mentioned, our waivers have always last 5 years. Some states have 3-year waivers. Next slide. So a little bit about what waivers are not. Like I already talked about this, how it's not the only way to change how care is delivered. We have lots of ways within the health authority to change care, and this coordinated care organizations also have ways to change how care is delivered. It also doesn't fix all parts of our healthcare system. It's really focused on our Oregon Health Plan. And so sometimes there are things that need to change that aren't part of our waiver that we still can look at. And Medicaid waivers are not a way to file a complaint about a provider or a service or a benefit that a member wants. I talked a little bit about this already, which is that we once we submit our waiver to our formal waiver, and that we will be doing that in February, then we spend time negotiating with the Center for Medicare and Medicaid Services. That's what CMS stands for, until we get to an approval. Next slide. I'll walk through where we've been so far in our waiver development, because these are big and we're thinking about big policy changes often. We have to start early. Like I mentioned, our waiver, the current waiver ends in June of 2022. We wanted to start even sooner, but it took a little longer for us to start going because of the pandemic. So we didn't start until late of 2020. At that time, we established a vision for our overarching waiver renewal focus, and that vision is to advance health equity in Oregon and for Oregonians. And then we reviewed existing public comment that we received from community. We reviewed strategic plans that were that had extensive community input to help focus what are the important policy areas that we need to change that will advance health equity. We heard from community or from various communities at that time that they were overwhelmed with COVID, and so said, hey, we have already told the health authority many times what we need and what's important, and so please go back and look at what you've heard. And so that's why all that public comment was reviewed before, and there was extensive public comment obtained around the COVID pandemic, for example. We developed draft concept papers on 4 big policy areas, and those were posted publicly in, I believe, June of 2020. And since that time, we've been engaging community, the delivery system, our CCOs, legislators, and a whole host of other people who care about the Oregon Health Plan and how we operate. And in particular, has been engaging also regularly with our tribal governments, the tribal governments that exist in Oregon, so the 9 tribes. Then we revised concept papers. Those concept papers based on all that input that we received across summer and early fall, and those were posted the 1st of November. Those concept papers then went into our final application. Not necessarily the final. When you look at the final application, it doesn't have all the concept papers just one after the other, but the vision and the information in the concept papers is included in the application. And this is a draft application that's posted currently. The draft application was posted on or around December 1st. Our public comment period started December 7th. It goes until January 7th. So we are accepting, public feedback and comment all the way through January 7th. During the rest of January, we will spend time incorporating that feedback into the draft application and then submit a formal application in February. The negotiations with CMS begin after we submit the application. Our current waiver ends in June 30th, 2022. And then the summer of 2022, a new waiver will be accepted. We may have to work on some pieces that we don't get completely finalized across the summer. And that also during that time, we have to begin really implementation. So I want to make it clear that this is a long process. So we will, we're working on big policy ideas now. And then starting in the summertime, we really get down to the detail about implementing and how we're going to implement the policies that are approved through changes in contract, changes in state rules and systems, and how we implement those changes with all our partners that we work with. Our new coordinate care organization contracts are updated every year, and so a new contract year starts in January. And some of the changes that we make will be in those contracts, and then some probably in 2024. So I described this a little bit too. We drafted the concept papers. I think they were important for two reasons. One is we submitted the concept papers at the beginning of November to the federal government. They've read them. We've met with the Center for Medicare and Medicaid Services, or CMS, twice since that time. And they've asked lots of questions about the concept papers, but it really gives them a heads up of what they can expect to see in our final application, and start to ask questions and become more clear on what it is we're actually asking for. The other piece that concept papers serve is allow us to start discussions with the public and all of the partners and communities and delivery system and providers that we work with, so that we can start to hear back about what's important, are these the right strategies, and that sort of thing. Those concepts then fully inform what is included in our waiver application, which is much longer. There's lots of federal requirements that have to be in there. And so it's very detailed and very formal. The purpose for that is to meet all of the federal requirements for submitting a waiver, and then also to start our formal negotiations. Next slide. These are the big concept strategies that we came up with after reviewing public comment and strategic plans. So I want to highlight again that our policy concepts are really designed to improve health inequities across Oregon. They were with that kind of overarching goal. We then developed four main concepts. There's 6 concept papers, and I'll talk a little bit about the other 2 in just a second. But these were the big policy areas, and that for the concepts that we released in June, and then there's concept papers for each of these posted now. The first is maximizing coverage. We know that insurance coverage for people in Oregon varies by community, and some communities of color have a lower percentage of people who are covered, and we want to close that gap. And also we learned during the pandemic about how important it is to keep people on the Oregon Health Plan. And there are many people who cycle through, they make a little too much money and fall off their coverage, and then they come back on. And we have some ideas about how to minimize that. The second big area, this is the orange box, and that we have a real focus on times of transition in people's lives. And those transitions can be from one system to the next, where they lose coverage, they lose their Oregon Health Plan benefits, and then come back on. So an example there would be if a person is involved in the criminal justice system, their benefits are suspended, and then they don't turn back on until they leave corrections. We also look at other kinds of transitions, like when children with special health care needs go from pediatric care to adult care, and that transition of becoming independent for a child or youth with behavioral health or chronic physical conditions can be very difficult. For those folks that are experiencing transitions, part of what we're asking for is to extend their OHP coverage, but also asking for important social determinants of health services to help meet their social needs. We know this is a tough time for folks. Another time of transition, for example, is for people who are homeless or at risk of becoming homeless. And it's important for them to have supports to find stable housing. You can't be healthy if you don't have your basic needs met. And so it's an attempt to meet people where they are in these times of transitions and help them meet basic needs and get the care they need. The green, can you go back, please? The green box is more about spending and how and encouraging our coordinated care organizations to spend dollars on health equity and social needs and other areas of care that keep people healthy and not just focusing on payment for medical services. The last blue box is to focus create some health equity investments, and this is to put money into the hands of community for people who have experienced historical injustices and really, understand what are the drivers that are going to help improve health equity in their communities, give them the power to make those decisions and the resources and funding to make those happen. Next slide. In our waiver application, we have to cover a number of topics, and here they are. And this is part of that, where we were talking about the waiver application being more formal. We have to describe who can be covered, who is covered by the Oregon Health Plan, or do we have any proposed changes in who's covered? And then for those people who are covered, what are the services that they can receive? And are there changes in our waiver from last time to this new proposed waiver in those covered services? The other piece is, are there any changes in how we deliver the care through our CCOs? And how we make payments for them. The fourth is incentive metrics. We pay CCOs incentive dollars for meeting certain metrics that show they are improving the care of our Oregon Health Plan members. We need to describe that, and that is the fifth concept paper describes big changes in our incentive metric program to have a much stronger focus on health equity. Budget neutrality, talked about that. We have to show the federal government what the dollars spent will be with this waiver, and then what the dollars would have been if we did not have a waiver. We have lots of what we call savings because we've had a waiver for a long time, and so we have estimates of what we'd be spending if we'd never had a waiver. And then finally, the evaluation plan that I talked about. I don't want to forget that our sixth concept paper we've been working on with tribes, and it's a tribal focused concept paper. Next slide. So I'm gonna, let's see, this is that's kind of the end of the Waiver 101 portion of my presentation, and I want to see if anyone has, or check in with Phil and see if anybody's asked questions so far, or if there's any questions in the chat.
There are no questions in chat at this time, but
Okay,
people are welcome to put questions they have along the way in there, and we'll stop again. Thank you.
Also, I'm just going to ask the team to message me if I need to speed it up.
We do, Lori, we do have one person with their hand up.
Oh, okay, terrific.
It looks like George Adams. George, I'm going to try to unmute you. there you go. It looks like you're unmuted.
Yeah, with this waiver, there is the ORS 461 for people that will be able to be on Medicaid. The changes that are taking there, is that going to change and mess up the 1115 waiver?
You know, I'm not familiar, George, with that statute. So we'll have to get back to you on it. I'm not aware of any statutes in Oregon where the waiver is going to cause problems. We have been, you know, observing House Bill 3353 that was passed last summer, and how the waiver, some of our waiver proposals affect that, but no other statutes have come up.
Well, the 461 deals with two parts. One with a person that has a disability, how are they going to be able to be on Medicaid? And the other part of 461 ORS is pregnant women, when they're pregnant and if they're going to be covered or not. It ties into Medicaid 1115 waiver.
Yeah, so the on the pregnant women side, I do know that there's a requirement that we, and maybe this is what you're talking about, there's a requirement that we cover 12 months of postpartum care for women, and we are implementing that. We don't need a waiver to do it, and I believe it's going to be in place for us in April of 2022, and so that is happening. I'm not aware of the others. I apologize, and we'll have to get back to you on that. But we are able to implement quite a few changes without having to put them in a waiver, like our 24-month coverage for postpartum care for women.
Okay, I was just curious about that.
Yeah, no problem. Thanks for the question. Okay, I'm going to go ahead and move on. And for some reason, my view, I can't see people. So the only box I can see is myself, which is really unnerving. Let's see. What I'm going to talk about now, and you'll recall just a few minutes ago, I was saying that we have to describe what we're changing and what we're proposing to change in the waiver. And so that's what I'm going to walk through today. And I'm going to do that for each of our big policy areas. So I'm going to start with the coverage piece, and we'll walk through the things that we're asking around coverage. And what I mean by coverage is people who either, how long they can be eligible and who can be eligible for the Oregon Health Plan. Next slide. So most people, nearly all people in Oregon have insurance coverage. I believe we're at about 92% of people in Oregon have some sort of health insurance. And what our vision is that we get up to closer to 98%. And I talked about this earlier, how there were differences depending on race and ethnicity in terms of the percentage of people who are covered. And our big vision is that there will no longer be differences depending on your race and ethnicity. We'll have 98% of all people in Oregon covered. Next slide. And here's the, on the right-hand side, you can see the actual data that shows that Hispanic or Latinx folks in Oregon have 12% uninsured insurance levels. This isn't just for OHP, but all types of health insurance. Similarly, American Indian, Alaska Natives, and Black or African Americans all have higher uninsurance rates than whites at 5%. And the other piece that is important that I think we're focusing on is when people lose insurance, they may miss healthcare appointments that they had set up when they did have insurance, and they can lose contact with their providers. And so not only are we trying to help ensure that everyone is insured, but also that they stay on their insurance so that they can make those healthcare appointments and have regular providers that they see. Next slide. We know that most people who are uninsured in Oregon are eligible for the Oregon Health Plan. In some cases, other low-cost health insurance around the marketplace. And about 60% of kids without insurance are eligible for the Oregon Health Plan. So I'm going to talk about these things that we propose to change in the waiver around coverage. And the first is what we call continuous eligibility for children. And that would be that kids, babies, young children stay enrolled until their 6th birthday. That would mean that if they are born and qualified for the Oregon Health Plan at birth, they would be able to stay on the Oregon Health Plan all the way until their 6th birthday. Or if they come on at, say, age 2, they can stay on from age 2 until their 6th birthday. Next slide. For everyone else, so that's youth that are 6 and older and adults, we're asking that they can stay enrolled on the Oregon Health Plan for 2 full years instead of 1. Right now, if a person becomes enrolled, their eligibility, they get to stay on for 12 months, and we're asking for that to go to 2 years or 24 months. Next slide. And then the last, this may not end up staying in our waiver. We may be able to do it with what's called a state plan amendment. And we're talking to the federal government about that right now. But the purpose of this is to allow people when they're applying for the Supplemental Nutrition and Assistance Program, or SNAP, over at the Department of Health and Human Services, if they're applying for those benefits and they're not covered by Medicaid, and when they give their income, they qualify, that they can be very easily enrolled in the Oregon Health Plan. And the purpose of this is to capture more folks who are eligible and give them the option to enroll. Next slide. What does this mean for our Oregon Health Plan members? First off, through that SNAP program, for example, it will be easier to enroll. And there's another doorway to obtain Oregon Health Plan enrollment and this is especially nice because now we have the integrated eligibility system. So when a person signs up for food assistance, they can be notified that they'd also qualify. And for current members, this is that idea of where I was talking about people staying on with their providers and their doctors and their appointments. That the other purpose of this is to allow people to keep their healthcare coverage longer. It's also doesn't require them to re-enroll so often. And overall, this it's not listed here as a bullet, but the big help for Medicaid members or future members is that, like I said earlier, all people who are eligible are enrolled regardless of their race and ethnicity. Next slide. Here's the next big policy area that I'm going to talk about, and this is related to the coverage around life transitions. So the big vision for this policy area is that people in Oregon have equitable access to services so they can be healthy and well and have their basic life needs met during times of transition, whether it's a time of transition because they're changing, from youth to adult, or from adulthood to elderly types of care, or if they're transitioning from one setting to another. Next slide. Why is this important? We know we've heard from advocates, we've heard from people who work in various systems that being in a major life transition, like leaving prison, like becoming homeless, or being a child who is entering or leaving foster care, that people, number one, often lose their health insurance or their Oregon health plan coverage, but they also lose care, and it's very it's a tough time in a person's life where they likely need more services and more helps in navigating the system, and at a time when they're actually losing care. So we're trying to fix, that's really the problem we're trying to fix. Next slide. So here are the strategies that we are proposing. These are areas where we're asking to change who's eligible for the Oregon Health Plan. So the first one is that when a person is in the criminal justice system, so if they're in prison or jail or local corrections, a youth is in under the Oregon Youth Authority, or a person, an adult, is at the Oregon State Hospital, that they would receive Oregon Health Plan coverage when it's normally suspended. The other piece that we're asking for to change the type of coverage is for youth with special healthcare needs. So this can be youth who are disabled, it can be youth who have multiple chronic conditions. Instead of ending their coverage at 18, they would be able to keep their coverage to age 26 so that they can keep their providers, transition providers from pediatric to adult, still receive the same types of mental health and behavioral health benefits that kids are eligible for. Next slide. And then I talked about those transition, those types of eligibility changes, or who can be covered in the Oregon Health Plan. And this is, once we've identified those people, we're looking at a bigger group of people who are in transition. So there's those getting out of jail and prison or leaving the Oregon State Hospital, but also people becoming homeless, children and youth entering or leaving foster care, also older adults who are moving from Medicaid coverage to Medicaid and Medicare coverage. So they're entering into the Medicare system. For all of these types of transitions, we're asking for additional benefits. And those benefits are what has traditionally been thought of as social supports, like housing supports and services. We're asking for rental assistance for up to 12 months. We're asking for health-related transportation services, some food assistance beyond what a person can get through the SNAP program. And we're asking the federal government that these services get paid for like medical services. Not for everyone on the Oregon Health Plan, but for the folks that are in these life transitions and for the time after they get out of that transition. Next slide. We're asking for a couple other, waiver strategies. So another covered service that we're asking to change is that we want to change some of the rules around that traditional health workers and peer support specialists have to follow. And what I mean by that is, right now, in order to receive payment, a traditional health worker or a peer support specialist has to work under a clinician or a physician or some other kind of medical professional. And we've heard from advocates and others in our system that many of traditional health workers or peer support specialists are working out in the community and they're not in the traditional medical model. So we're asking that they can still be paid without that same clinical oversight. And we're also asking that members can receive those services without having it to be documented in a treatment plan. So those are some details, but the whole idea behind this is to allow people on OHP to have access to traditional health workers, community health workers, peer support specialists who can help them navigate the system in a culturally appropriate way. We see this as being really important, particularly for those folks who are in transition. We're also asking for some extra federal funding. So another thing that we can do with an 1115 waiver is ask for the federal government to give us extra funding. And I know I said this has to be budget neutral, right? You'll remember at the beginning, I said that we need to make sure that we're not costing the federal government more money. In Oregon, we've saved the federal government through our waivers across the years. And so we have some room to be able to say, okay, we saved you dollars by providing better care at a lower cost, and that we would like to take some of that savings and use it now. And the areas where we're asking for some federal funding are to pay for those social support services during, that we're proposing, like housing supports and services, at least to get federal match dollars, so that we can provide those services and not just have them funded by the state. And then also allowing some additional funding to go for kids in child welfare or foster system around, so that you have better access for psychiatric residential treatment services. We're asking for federal dollars also in another one of our other policy areas, and I'll talk about that in a little bit. So what does this mean for Medicaid members? First off, this would provide more coverage for people who are leaving Oregon State Hospital, jails, juvenile corrections. For kids in the Oregon Youth Authority or in juvenile corrections, we're asking that they keep their Medicaid through the whole time. We're also asking that people stay on the Oregon Health Plan during an entire jail stay. For the other folks in prison or Oregon State Hospital, we're asking that they get coverage 90 days before they are released. And that coverage is important so that they can connect with traditional health workers or other navigators who can help them set up appointments, get assessments early, and start to access some of these housing services, for example, so that things are set up when they leave. For youth with special health care needs, they will have coverage that lasts longer so that they have a longer time to prepare for adulthood. Another piece that I haven't talked about at all is another important transition that many of you have experienced across the last year is around extreme weather events due to climate change. That might be a wildfire, the extreme heat events we had. We're asking for supports for folks like transportation to a cooling center or a warming center if needed, to an evacuation place. We're asking for air cleaners, air conditioners, those kinds of things. Youth in foster care and their families will receive these social supports along with elderly adults who are moving into Medicare. Next slide. This is the third big policy area. I'm going to be talking about some payment here. I'll move on to the next slide. So our vision here is that Oregon's way of paying our coordinated care organizations is predictable but flexible. And what we mean by that is that the coordinated care organizations would have more flexibility in how they can spend those dollars to meet social needs, to improve population health, and keep people out of the medical system. Next slide. And why is this important? Right now, the way that our CCOs are paid, and frankly, the health plans in other states too that cover Medicaid, is they're all paid in a way that focuses on spending on things that happen after a person is sick. So doctor's appointments, medical procedures, hospitals, and we believe in Oregon that CCOs should focus on and be paid in ways that encourages spending on health equity, keeping people healthy, population health, and improving the health of communities. And so we're asking the federal government to have the allowance to pay for health. Next slide. I'm going to walk through the waiver strategies in this area, and they're focused on rate setting, what's called the words in the green there, rate setting methodology. What that means is that we pay the CCOs a funding amount every month for every person that they have covered. And we have a method or a way that we figure out how much that CCO is to be paid. We're asking to make some changes in how that works, so that CCOs are encouraged to spend more money on health-related care and population health for members. And that once we set a base budget. So at the beginning of the waiver, we'll figure out a base budget for those coordinated care organizations, and then their budgets would increase in a simpler and more predictable way from year to year, so that they understand how much they're going to receive, so they can plan and make system changes, and that they're not so focused on how much they've spent on medical care in the previous year. Next slide. There is also some discussion in that policy paper on how drugs are covered. And this is to better control the cost of medications. Many of you probably know that prescription medication costs are just really rising and have been for a long time. And it's some strategies to reduce the cost to the state on those prescription medications. And what does this mean for Medicaid members? The real piece on this is that the focus is on improving health equity, population health, community health for members. And so by changing how these rates are developed for our coordinated care organizations, it will give the coordinated care organizations more flexibility in their spending for the members that they care for. And the methodology will be simpler to explain to people. This is the concept paper on metrics. I talked about it a little bit. It wasn't in one of the boxes at the beginning. And so this is a concept paper that describes how we want to change our incentive metric program. Next slide. Oregon has a very innovative quality metrics program that we've been using since 2012 at the beginning of CCOs. And our vision is that quality metrics program will use equity as its primary organizing principle. What I mean by that is really the focus of the metrics will be equity and measuring how well CCOs are improving health equity across their members and the care they provide. Next slide. And why is this our vision? First off, like I said, we've been running this program almost 10 years now, and we know that the coordinated care organizations really focus on those metrics that they get paid for. And so if we want to drive change, a really strong way to do that is through measurement and paying for changes in measurement, and therefore focusing on equity is a way to move health equity and eliminate health inequities across Oregon. Next slide. So how are we going to change those metrics? We're going to split the program into two types of metrics. You can think of it health or our population health as a river, So upstream of that river are the kinds of things that you might think of that help a person be healthy. The social determinants, the factors that really make a person healthy. And then downstream, a person might then lives in their community, receives care, and the downstream metrics are the kinds of measure the kinds of care, access to care that our Oregon Health Plan members receive. So we're going to be focusing on two areas. The upstream metrics, the focus is on the root causes of health inequities. And so these metrics would focus on things like meaningful language access to culturally responsive care. So are our members receiving language interpretation services? Are they receiving culturally responsive care? Another upstream metric would be screening for social determinants, or for social needs. So understanding how many of our members are really in need of housing, in need of food assistance. We are proposing that those upstream metrics stay the same through the whole waiver period so that we can drive real change. The downstream metrics measure our medical system, and those metrics are important for us to be able to understand how well the CCOs are performing. But we will have the ability, at least for many of the metrics, to stratify or to break them out by race and ethnicity so that we can see where their disparities exist, and then support that change with our incentive metric program. Next slide. The second part here, where it says more decision-making power is given to communities. We also are proposing that the program be redesigned so that right now we have what's called a health plan metrics committee, quality metrics committee, and that committee we are proposing to change to be a health equity health metrics committee. And so it would be comprised of members of the community with an equity focus, and they would have oversight of the metrics program. And the goal of this is to redesign the program and the decision-making to advance health equity across our system, and be able to measure where we're improving and where we still need to go. For Medicaid members or our Oregon Health Plan members, this means that communities will have a greater voice in what's measured and what's focused on by the CCOs, and be able to track and monitor where we're improving in health equity and supporting the CCOs and making those changes. Next slide. This is our last concept paper. I've been talking a lot, so hopefully you're still with me. This is the last big concept paper that I'm discussing tonight, and this is on focused equity investment. So the vision for this is that we are not going to be able to improve health inequities in Oregon without having the community lead the solutions and the community have the ability to make decisions about what those solutions are, and then oversee the investment in improving those areas of inequity. Why is this important? People don't have access or equal access to important resources. We know that people in our state who've experienced historical racism and injustices have needs that they understand better than anyone else in terms of how to improve their health and how to keep folks healthy, how to change our systems so that all people in Oregon have access to and quality, access to healthcare and high quality healthcare. At the same time, we believe that I talked about this a little bit earlier, how we have savings from our waivers, and we are going to be asking the federal government to help fund these initiatives, these community-led initiatives. Next slide. So what are the waiver strategies that we're asking for in this policy initiative? We are asking for federal investment and some state investment towards these initiatives, and they will be community driven through what we're calling community investment collaboratives. These investment collaboratives need to have a lead entity that's community, and additionally, a financial entity that can be the same who oversees the spending. The collaboratives will involve members of the community and community organizations, along with some of the, community advisory councils from CCOs and other parts of the delivery system, to come together and determine what are the areas that need focus and what can be funded to improve health equity. The funding comes, like I said, this would be new dollars that we're requesting from the federal government. And then also the coordinated care organizations would be required to spend a certain amount of their budget to support the collaboratives as well. And this combined funding would then allow all people at the table to, come together with, bring the medical side together with our social investment side and the people who are working on social needs and directly with community to work together towards common solutions. Next slide. So in this policy document, we really have to ask the federal government about spending state money in new ways. We're asking that the funding that this coordinated care organizations put in be count as a medical spend, so that we get federal match for that, federal dollars. And then we also are asking the federal government for new funding to support our community investment collaboratives. Next slide. What does this mean for Medicaid members? It will give Oregon Health Plan members a voice in decision making, and the ability to decide and weigh in on what investments are going to be made in health equity within their communities. And overall, the overall goal for our Medicaid members is improved health, and particularly for those members harmed by historic and contemporary injustices. Parts of our current waiver, I do want to highlight this because, I mentioned that our waiver has been renewed every year for 5 years, every 5 years since 1994. And there are pieces of the waiver that we keep. So it's not all brand new. There's authorities that we've had, some since 1994. And so this is just a quick rundown of some of the areas that we are plan to renew and not change. The first is...
Hey, Lori.
Mm-hmm.
Sorry to interrupt. We have a question
no
that really relates to the last slide, the last couple slides from Dan Cushing. It says, what is meant by, quote, community? Is it race, ethnicity based, or other marginalized communities part of that? Who defines it, and to whom are these community groups accountable?
Yeah, great questions. So by community, community is a broad term, so I appreciate the question. We've developed this concept paper with, it's been a collaborative effort with the Oregon Health Authority, along with the regional health equity, some members of regional health equity coalitions, and some other community organizations. We definitely see community being people who either are part of the community or part of an organization that works in a community of color, or have experienced, historic injustices. Now that could also be the disability community, for example. So it's, and in fact, we focused that on our definition of health inequity. So if you, which encompasses people of color, people who speak different languages, people with disabilities, and folks who may identify sexually or have a sexual orientation that's self-identified and have been historically marginalized. So it's a collection. And in terms of who's accountable, in House Bill 3353, there is a oversight committee that is required. And we see that the oversight committee, which I believe has to be approved by the Oregon Health Policy Board, the Oregon Policy Board, or sorry, Oregon Health Policy Board, but it lays out who it is, who's on, and it's representative of communities of color. That oversight committee would be major part of the accountability. If we do receive the additional federal funding, there will be some accountability to the Oregon Health Authority because the funding will come to us and we are ultimately accountable to the federal government for those dollars. Thanks for that question. Anything else, Phil?
Not at this time. Thank you.
Great. So what's unchanged? The first is we have a Health Evidence Review Commission, which is a public entity. They meet in public meetings and determine the benefits that we cover in our Oregon Health Plan. Those benefits are called the prioritized list of health services. And so we are asking that we continue that method for determining what's covered for our Oregon Health Plan members. I mentioned this earlier, but our coordinated care model, our coordinated care organizations is all based in a waiver that was passed in 2012. And we are continuing that unchanged in the waiver. There's some discussion around how we pay CCOs and value-based payment methodologies or value-based payment systems in how OHA pays our coordinated care organizations, and we're keeping that. There's commitments to the healthcare quality and access for our Oregon Health Plan members that we will continue. We plan to continue the community advisory councils that each coordinated care organization has. And then there's in attachment I, extensive description of how both our coordinated care organizations and the Oregon Health Authority engage with tribes, and we will continue that. It's not discussed in our meeting today, but I do want to call out that we also have some new policy areas that are specific to tribes included in our waiver application. And we've been working with tribal governments on that. I think next slide. Hildy, are you going to discuss the survey or shall I?
Yeah, I can discuss the survey. Thank you, Lori.
And before we do that, let me check in with Phil and see if there are any other questions.
Great.
I do not think there are at this time.
So I want to thank everyone. I know that was lots, and it's lots at the end of the day. So thanks for sticking with me, and I'm going to turn it over to Hildy.
Great, thank you, Lori. Before we begin the public comment portion of this evening's meeting, we do have a survey. We'll add the survey link to the chat so you can find it there. This survey is part of our efforts to improve the public engagement process and to understand the people and organizations attending events about the waiver. The survey asks several questions about your demographics, whether you are a provider or from an organization, and if so, who you serve. These questions are optional. The survey is optional, but if you do answer the survey, and we do hope that you take it, The information will be kept confidential. Next slide, please.
Hildy.
Yes.
We did have a couple late-breaking questions coming in
Oh, great.
that I would love to read to Lori. And they are so Hildy is going to say this in a moment, but to all of you listening, clarifying questions asked in the chat are going to be about clarifying. They're not considered to be public comment. The next section of the presentation will be public comment. So what I'm reading are clarifying questions now. So the first story is from Leilani Brewer, who says, can we learn about some of the strategies for the 6th concept paper with focus on tribes? We have 2 more after that.
Sure. I'm going to run through a couple, and we may have to get back to folks because I know it won't be comprehensive, but there's what's called a tribal uncompensated care program that we're proposing to continue. So that's one. The other is around tribal. I think the big one is around tribal-based practices. So the Oregon tribes have come together and created, they have a tribal-based practice committee that has developed a list of, I believe, 21 different tribal-based practices. And what these are non-medical practices that promote health and well-being for tribal members, and they're traditional and have been, many tribes been happening for hundreds of years. And so we just made the first payment for one of those tribal-based practices called Equine Therapy, and they need to be for conducted by tribes and for tribal members. That's the only one that we have approved. And so we're asking the federal government whether there's a mechanism that we could have others approved without having to go through a full waiver, waiting every 5 years to implement a new tribal-based practice. So that's one of the big focus areas. Another is the tribes would like to have some of their members, so by federal law, a tribal member can decide whether they want to be in a coordinated care organization or be in fee-for-service, or what we call open card. They're one of so they have choice, and many members are open card and obtain services in tribal clinics and at the urban tribal clinics as well. And so they've asked that that their open card members who are going through transitions have access to the same types of social supports that we have in this in the concept paper, the second concept paper I walk through. I know those are 3 things, and there may be a couple more, but I don't have them on the top of my head. Hopefully that was helpful.
Thanks. The next question is from Mercedes Eliazde. Probably say this wrong, Elizalde. She says, how will the CICs be established? Would OHA be charting and recruiting for those, or would the CCOs be responsible for coordinating the formation?
Really good question. And I have to say, that we haven't, we don't have any formal, formal decisions on that yet, but the idea is that they would likely be formed through OHA and the Oversight Committee that I talked about, that's in 3353. We're hoping that communities come together to form, and then likely approval would go through the Oversight Committee with some input from the Oregon Health Authority.
Okay, Lydia Dennehy says, on the prioritized list, there are lots of conditions that are linked. For example, TMJ for children with disabilities who do a lot of chewing and teeth grinding. Will you be able to treat them?
I'm not, I don't know the list well enough. So, you know, we have on the prioritized list of services, if the treatment or service is above our funding line, then yes. If it's below, and for children, if it's deemed medically necessary by a physician, then we can pay for that. So I don't know it well enough off the top of my head to answer that question.
And I believe we could get
Take that
back
off
to
my-
we could get back to this person with some more detailed answers.
Yep.
Lastly, I think that George Adams has their hand raised one more time. So I think that concludes the chat questions. We'll see what George has to say and then move to public comment.
Yep.
Hi again.
Hi, George.
I know I've asked this before in the recent meetings that we've been having, but with this waiver, has there been any indication or anything being worked on as far as bringing the income limit up for people to qualify?
Yeah, we haven't. The only place that we're asking to bring the income limit up is for those kids, the youth with special health care needs. Right now, and this is a little complicated, for youth, kids are covered under Medicaid, cover all kids or Medicaid, but then also for families that have a little bit higher income, up to 300% of poverty, there's a program called CHIP, and that covers kids in Oregon up to 300% of poverty if they're above the Medicaid, which I think is 133. And so we're asking that they get, and I believe Affordable Care Act adults are covered up to, I think it's 138. Sorry. So if a family was in that little gap between 300 and 138, then the youth with special health care needs, when they become an adult, fall off coverage. So that what we're asking is that they get to keep that higher income all the way till they're 26, so that they can stay on longer. That's the only one that we're asking for with a higher income limit. The income limits, we really can't, they're not necessary. You know, for example, if we wanted to pick a whole category, those are harder to get approved, and we didn't ask for any beyond that.
Well, how much more will the CAC have to do once it's approved next year?
How much more what? I'm sorry, I didn't hear the rest.
How much more will the CAC have to do in the CCO once this gets approved next year?
You know, that's a good question. We are keeping the CACs, or the Community Advisory Councils, under CCOs in our waiver. And we think they're a really important voice and piece, you know, in our coordinated care model. But I don't think we'll be adding lots of extra work, except that CACs may want to be involved in these community improvement collaboratives. And then there's potentially that work around, you know, the investments in health equity.
Okay.
Great. Hildy, I'm going to turn it over for public comment.
Great. Thank you, everyone, for your questions and your engagement in the presentation. So we will now begin the public comment portion of this meeting. I'm just going to explain a little bit about how it works, and then I'll explain a few other options if you're not ready to provide comment today, but would still like to provide comment. So the Oregon Health Authority welcomes and deeply appreciates public testimony. Today's forum provides an opportunity for members of the public to enter their comments into the public record. This is a record of accountability. We will be listening intently today, but we will not be responding today. We will be documenting comments exactly as they are presented by the speaker. And when the public comment period for the waiver draft application ends on January 7th, We will then review and respond to all verbal and written comments that we have received. Responses to comments will be posted on the OHA website in mid-February. So each presenter will be given 2 minutes to share. And in the event that that doesn't feel like enough time to fully express your comment, we encourage you to provide written testimony. So to keep us on time, we'll start a 2-minute timer for each presenter, and we kindly ask that each presenter concludes their presentation when the timer is complete. When it is your turn, we will unmute you, but if you are on the phone or your name does not appear in your Zoom chat box, you will need to send a message to the meeting host, Michelle Hatfield, so she knows who to unmute. Otherwise, your name appears as a phone number or just something else, so we're not really sure how to unmute you unless we have that information. So you can send, you can also send a direct message to sign up to give a public comment, or it seems to be working pretty well if people raise their hand. If you do provide public comment, please state your name and state your organizational affiliation if you are here speaking on behalf of an organization. Next slide, please. So if you do not provide public testimony today, you do have other opportunities to provide comment in writing or at another public forum. After today, there will be 2 more opportunities to submit verbal comments, including tomorrow, December 17th, at the Community Partners Outreach Program webinar, and on January 4th at the Oregon Health Policy Board meeting. These meetings are listed on the OHA website, and you can also provide comment in writing through the 1115 waiver webpage, through email, or by clicking on the survey link that was shared in the chat. If you would like to receive updates about the waiver, including when those responses to public comments are posted, you can also sign up for that through the website. It's listed in number 1 on your screen here. So we will now open the public forum. Our first request for public comment is from Daria McGrew. Welcome, Daria. Please state your name and affiliation for the record, and we'll set a 2-minute timer. Hi, and you can begin when you're ready.
Great, thanks. Daria McGrew on behalf of PhRMA. We understand the state of Oregon faces considerable challenges ensuring residents have access to quality, affordable care, and applaud the agency's goals of improving equity and closing gaps in health disparities. Aligned in that priority, we believe in building a more just, equitable healthcare system and believe that diversity, equity, and inclusion are essential to the discovery of new medicines that people of all ethnic and racial backgrounds should have access to treatment, and heartened by the state's commitment to improving that. However, Oregon's proposal to impose a closed formulary would not promote the state's laudable goals of advancing health equity. Your concept papers and the presentation tonight highlighted known existing health disparities and some of the issues that led to these among OHP members and communities of concern. Research shows that limiting formulary choice can lead to worsened health outcomes and ultimately can increase costs to the system rather than producing the intended savings. The pandemic has had harmful effects on the social, economic, and healthcare related outcomes among lower income and racially and ethnically diverse groups, and therefore timely access to provider recommended medicines is central to reversing that trend, improving health outcomes, decreasing avoidable healthcare utilization and costs, and reducing mortality. The proposed amendment will impede access to medically necessary drugs for more than 700,000 Oregonians, and it raises serious concerns about the long-term impacts. Moreover, the proposed amendment doesn't meet the fundamentals of 1115 waivers and picks and chooses which parts of the Medicaid rebate statute to abide by. We will be submitting full comments that flesh this out in much more detail, but appreciate the time and to briefly speak here tonight. But in summary, PhRMA believes closed formulary proposal is ill-advised for both legal and policy reasons and should be withdrawn from this application. Thank you.
Thank you for your comments. The next person on our list to provide public comment is Josh Balak. I'm not sure that I see Josh in the chat. Josh, if you could raise your hand if you are in the meeting, then we will know who to unmute. Okay, so we will come back to Josh if there are any other comments. I don't have anyone else on the list who has signed up. So if there is anyone in the audience who would like to provide public comment, please raise your hand. So it doesn't appear we have any other takers to provide public comment. So with that, I want to thank everyone for attending today. Your interest and participation is very much appreciated. I'd like to thank Lori for presenting, the interpreters, Amanda and Christopher for providing interpretation services, and everyone, all the staff who worked behind the scenes on today's event. So thank you so much. Have a nice evening, everyone.